The topic of today's lecture is the retinal detachment. So, how do you define this condition is quite significant over here. First of all, just reviewing the basic applied anatomy of the retina, we can recall that retina is the end organ for the vision. It's responsible for relaying messages to the visual cortex, and the final interpretation is done in the visual cortex. But obviously, the interpretation depends upon the messages that are sent back to the visual cortex by the retina. So, if there is any hindrance between the interpretation or between the grasping of the messages at the retina, that can really affect the vision of that individual. When we define this condition of retinal detachment, we basically mean that it's a separation between the neurosensory layer and the pigmentary layer of the retina. So it can be classified as a misnomer over here. It's not the retinal detachment in the true sense. It's the separation of the neurosensory and the pigmentary layer, and the word separation would be a more appropriate word rather than the detachment that is a misnomer that is used for these conditions over here. So we'll be discussing these clinical condition over here. First of all, just reviewing the applied anatomy of the retina. So comparing a healthy eye, we knew that there are basically these three protective layers that are present around the eyeball, known as the sclera. We have the choroidal layer, and finally, we have the retinal layer. So these are the three basic layers that are providing protection, and they have their own functions as well. Just by reviewing, we would recall that retina has the neurons that are basically sending back messages. The choroid is having the choroidal plexus that is mainly responsible for the blood supplying capacity towards the eyeball. So over here, just reviewing the basic anatomical structures, we can just recall that we have a lens that is located anteriorly. We have the retina that is basically more posteriorly located, and we can recall that it has an ora serrata, that is basically the margin line of the retina that is placed most anteriorly. Then we can recall that there was an equator of the retina that basically encompasses half the way between the retina and the ora serrata. So these are some of the terminologies that we would be using regarding this condition, which is known as retinal detachment. So that is why I'm highlighting these over here. And then we have the cornea, of course, that is most anteriorly located. We have the fovea that is in relation to the retina, of course. So there was a place, or there was a location on the retina that was responsible for the most central vision of the individual, and that was regarded as macula. Macula, most centrally located, it has the fovea centralis or fovea, and any abnormality or even a detachment that is placed in the fovea, or either it is placed in the macula, is going to affect the central vision of that individual. So again, we should focus on the facts that the location of the retinal detachment would also be affecting the final loss of vision in that particular individual, whether it is a peripheral loss of vision or whether it is a central loss of vision is going to depend upon the location of the retinal detachment or any abnormality of the retinal detachment, obviously, in certain other cases. As you would like to see, you can appreciate there is this diagram which is roughly showing you how a retinal detachment would look like. So this is how a retinal detachment would look like. There would be a potential space between the retina, and it's basically this space would be located between the pigmentary layer of the retina and the neurosensory layer of the retina. So in other words, we can justify that it's basically just a retinal separation in itself rather than the retinal detachment between the choroid and the retina. So there would be this potential space created. Now, again, there are multiple reasons for the making up of this potential space between these two layers of the retina. Either it can be the inflammatory processes, the exudative processes, we can call in other words. Then we can have a lot of tumors, that is, the neuroblastomas can be present over here, which can again relate to this potential space. So they can be the underlying cause towards the development of this potential space between these two important layers of the retina. On the other hand, we have the regmatogenous causes for the development of this potential separation between these two important functional layers of the retina. When we say it's regmatogenous, it means that there are no other particular causes for the development of this condition. That is, there is no inflammatory process going on, there are no systemic causes for the development of this. There are no causes that are related to the tumors or the neuroblastomas. It's just the retina itself that is creating this potential space between the two layers. This class or this group of retinal detachment is basically due to the retina itself. It can be the retinal degenerations, it can be the retinal tears, or it can be the retinal holes that are responsible for the development of this regmatogenous or primary retinal detachment in this particular individual. So you have to keep in mind these three major classifications. How do we clinically classify this condition of retinal detachment, and that is responsible for this particular kind of the clinical presentation or this particular clinical picture in an individual. As you can see, a retinal tear is basically giving way to this potential tear even in this scenario that we are seeing over here. So it's basically the retinal tear, so it's a regmatogenous kind or a group of the retinal detachment or the group of diseases which undergoes this regmatogenous kind of a retinal detachment or a primary retinal detachment, it's again known as that. So basically, when we just examine any patient who is suffering from retinal detachment, or we are suspicious that this particular patient can be put into the classification where the differential diagnosis may relate to the retinal detachment, we'd look for the sign and symptoms in this particular case of retinal detachment. So it's usually, as the name indicates, and as we've already focused on the factors, that it's the collection of fluid under the retina in a retinal detachment that is very important. That was the mainstay of the definition when we are talking about it. And where is this fluid being collected or being accumulated is again very important. It's the potential space between the pigmentary layer and between the neurosensory layer of the retina itself. So over here, we would be just focusing on the fact, or we'd be just appreciating that there should be fluid under the retina in the retinal detachment, as you can appreciate over here. How would it appear? It would be a pale appearance rather than a reddish appearance. And then in the center of the macula, it remains attached. So if the center of the macula it remains attached in this particular scenario, it's not going to affect the central vision of this particular patient. But if the macula is involved, or if the fovea or the fovea centralis is involved, then it is going to affect the most central vision of that individual. There would be loss of vision that the patient would be complaining of, and again, we'd be focusing on the fact that it's a painless loss of vision in these individuals. So it would not be associated with any sort of pain if it's particularly the primary or the regmatogenous kind of the retinal detachment that we're talking about. Then it would be just the loss of vision, and the loss of vision is going to be again related to the site of the retinal detachment. It's also known as the Linkoff's rule. The site of the attachment is again very important. The gravitational forces, obviously, they come into play whenever there is a fluid collection between these two layers of the retina. There would be a gravitational forces that come into play. And again, the field of vision is going to be related to the location of the retinal detachment in these individuals. So this rule or this clinical scenario is going to be related to the Linkoff's rule over here. So again, obviously, the ophthalmoscopic findings are very important whenever we are going to relay the clinical features along with the final outcome of the loss of vision. We're going to know that what are the particular rules that this particular disease is going to follow over here. As we can say, the classification is usually etiological. Etiological basically means the underlying causes that give way to this particular kind of retinal detachment, or the development of the exudates, or the development or the accumulation of certain kind of fluids between these two layers. So the classification is again etiological. It's depending upon the causative factors over here. So we'll be discussing this classification. There are these three major categories that we have to keep in mind. First of all, we have the rhegmatogenous or the primary retinal detachment. So rhegmatogenous, as the name indicates, it's basically the retina that is primarily involved in these conditions. Now, what are the different causative factors of the retina itself? It can be the lattice degenerations, particularly. They are quite notorious for the development of this kind of primary retinal detachments. We have the snail track degenerations, we have retinal tears, we have macular holes. All of these conditions can basically relate to the rhegmatogenous or the primary retinal detachments over here. Then the second major group is the tractional or the retinal detachment. So what is the cause of the traction over here is very important. It's basically, it can be the neovascularization. That is again, can be a secondary condition due to the lattice work degenerations or due to different kind of dystrophies of the retina that we talked about, and that resulted in neovascularization. And this neovascularization can basically pull off a fibrovascular network that maintains this tractional force on the retina. So if it's the retina has that primary causative factors, whether it is a hole or whether it is a tear, and is coupled up with these tractional forces, it's again going to highlight the situation, and the end result would be the development of the retinal detachment in these individuals. So these can be the final outcomes, but the underlying causes are very important that we have to focus on. Then the third and the last group is the exudative retinal detachment. So as the name indicates, exudation is basically referring to the inflammatory processes or due to the infections. It can be one of the causative factor over here. So even these exudative causes, whether these are the infections, primary infections, or it can be any other secondary infections. For example, it can be any inflammatory, long-standing inflammatory conditions. For example, diabetes, or it can be the SLEs. These are the long-standing systemic diseases that can result in the accumulation of fluid between these two layers that we were talking about. It is basically the neurosensory and the pigmentary layer that we're talking about, and that we have to keep in mind. So a lot of systemic diseases, a lot of conditions which can be primarily due to that particular area. For example, a lot of tumors can even relate to using up of this potential space or covering up this potential space between these two layers of the retina that we talked about. So these three major categories that we have to keep in mind relating to the primary retinal detachment, mainly just focusing on the factors that were related primarily to the retina itself. So we have to focus on the focal pigments, on the focal clumping phenomena that can occur in the retina over here. Then finally, the investigations, the sign and symptoms that we have to look for in these patients is very important. The ophthalmoscopy is going to reveal a grayish hue in the retina. So this is going to regard as a site for the retinal detachment over here. We have to look for the color changes. It can be the shape changes according to the retinal tear or according to the retinal hole that we can talk about. Now, these retinal tears or these retinal holes can be of different shapes that we have to look for. Even it can be the horseshoe-shaped phenomena, a rounded phenomena, or a primary phenomena, a rapid vitreous hemorrhagic phenomena that we can see over here. There can be pigmentation of different sorts. There can be hemorrhages that can be located. Whenever we are viewing the retina, whether we are using an indirect ophthalmoscopic method or either we are using a direct ophthalmoscopic method for these patients. But we have to look for these particular signs and symptoms in these patients. The etiology of the primary retinal detachment is basically focusing on, we can also relate to these as the risk factors for the development of the retinal detachment in these individuals. Gender, again, is very important. The sex of the patient is very important over here. Usually, the males are more predominantly affected by this kind of a condition, which is known as the primary retinal detachment in these individuals. Then the high myopes or the long-standing myopes, these are more affected, they are more affected than the normal population. So usually you will get a patient who is a male, who is a long-standing myope, and basically this myopia is pulling off those tractional forces on the retina that are responsible for the final outcome of the retinal detachment in these patients. Then aphakia and pseudophakia. So these patients who are aphakic or who are pseudophakic, they are more prone to the development of primary retinal detachment. Then patients who are suffering from retinal degenerations. The most notorious degenerations over here are the latticework degenerations and the snail track degenerations that we can talk about. Then we have white with pressure and white without pressure conditions. We already talked about these pressuric states. It is basically the pressure that is put on the sclera. The scleral indentation basically reveals this kind of retinal detachments over here. And then we have the retinoschisis. Retinoschisis itself is the separation between the neurosensory and the pigmentary layer. And obviously, this slight retinoschisis phenomena is going to put away or make the foundation towards the retinal detachment. That is the final picture in these patients over here. Then we have trauma. So trauma can basically be a secondary cause for the development of primary retinal detachment in these patients. On the other hand, we have senile posterior vitreous detachments. So when we talk about these age-related vitreous detachments, it's basically the retina itself that has been subjected to a lot of wear and tear due to the development of the age or due to the advancing age. It can be a retinal macular hole or any other retinal tear that can give way to the retinal detachment after the tractional forces they come into play due to any infectious states or due to any long-standing inflammatory conditions in these old patients. On the other hand, we have the age, obviously, the age group of 40 to 60 years. So it's usually this age group, which is the fourth and the sixth decade of life, that is most prone to the development of retinal detachment. So these are basically the list of risk factors that can be related to the development of rhegmatogenous or again the primary retinal detachment. These can be the causative factors towards the development of this kind of the group of conditions. Discussing the pathogenetic factors or the pathological processes that are basically underlying this kind of a primary retinal detachment is the senile posterior vitreous detachment. This is the starting event for this kind of the condition to develop. Then it is going to relate towards the retinal break. Now this retinal break can be of any kind. It can be a retinal tear, a retinal hole that can basically give way to the development of this detachment kind of conditions. Now, this retinal break is basically caused due to the retinal degenerations or the retinal dystrophies that we had already mentioned. These retinal degenerations are going to predispose the retina towards the development of the breaks in these patients. Even traumas of any kind. It can be the endogenous traumas, that is basically the infectious states or the inflammatory conditions in the patient, or even it can be the external traumatic conditions that give way to the development of the retinal breaks. Then a lot of conditions, for example, aphakia or pseudophakia, they also give way to the development of these retinal breaks in these patients. And obviously, after these retinal breaks or after the development of this potential space between these two layers, there is the accumulation of the degenerated fluid, which basically sweeps into this potential space. It's basically the liquefied vitreous that is going to enter into this potential space between these two important functional layers of the retina, and the final outcome would be a retinal detachment. In these cases, the collection of the serous retinal fluid is going to give way to the development of the retinal detachment in these patients. Then finally, the clinical features. So the group of clinical features that would basically encompass the signs as well as the symptoms that the patient would complain of. The normal regular symptoms would be a painless loss of vision, a grayish hue that is created in the visual field, and the scotomas or the photopsias that the patient would complain of. The group of symptoms can be divided into prodromal symptoms in these patients that the patient would complain of before the complete loss of vision that is experienced by the patient. So the clinical features can be divided into the prodromal symptoms. The prodromal clinical features are the photopsias, that is basically the flashes of light that are observed by the patient. So the patient would usually complain about floaters or flashes of light that are quite distinctive, and they're observed by the patient for it can be an acute duration or a chronic duration depending upon the type of disease that is responsible for the retinal detachment. So again, it can be the floaters or the dark spots that we can talk about. It can be the visual field effects that have been noted by the patient. So these prodromal symptoms or this prodromal phase is again very important. If you have diagnosed the patient to be suffering from retinal detachment, or any retinal detachment is about to occur in that patient, and you have clinically signified this patient, the prognosis in these patients is very good because you can apply a lot of treatment modalities in these patients, and the final outcomes would be very good in these patients. Then we have a detached retina symptoms that would basically include the loss of field of vision in these patients. There would be a dark cloud or a veil that the patient is complaining of, and the loss of vision would be painless. So the differential diagnosis would be of a painless loss of vision in these patients of primary retinal detachment. The signs would basically include the normal external examination is very important, and it's usually quite normal. There are no significant changes except for if it's a case of trauma that would basically be having the signs of trauma even externally. Then the Marcus gun pupil. So the afferent pupillary defect that we already noted down, whenever we perform the pupillary reflexes on these patients, there would be a grayish pupillary reflex that is noted down, and there would be a pinpoint pupil, and this kind of a pupil is basically regarded as the Marcus gun pupil in these individuals. We can perform the distant direct ophthalmoscopy for these patients, and the intraocular pressure is usually normal, or it can be even lower down in these individuals of retinal detachments. The signs would appear on the scleral indentation. So that scleral indentation is again very important, and that would basically highlight all the signs that we talked about relating to the grayish hue or relating to the different ophthalmoscopic findings upon the ophthalmoscopy. There would be a gray reflex that is noted down on ophthalmoscopy, and basically the retina is raised anteriorly in these patients. So these are these particular signs whenever we dilate the pupils and we are looking at the fundus of these patients. These would be the particular signs that we are focusing on in these patients. If there would be folds that are oscillating with eye movements, especially the rapid eye movements. They are usually related to these oscillating folds in these patients. Then the small, or usually it's assuming the shape of balloons. These scleral indentations would reveal these kind of balloons or these oscillating folds in these patients as well. The retinal vessels, they appear as dark, tortuous cords. These are basically the arteries and the venules that are exaggerated or that are accentuated in these patients. Then talking about the retinal breaks in these patients, there are different shapes for the development of these retinal breaks. Either it can be the horseshoe shaped, as you can appreciate over here, and then also it can be a rounded shaped tear that is giving way to the retinal detachment in these patients. And then we have the anterior dialysis that is relating to a whole hemorrhagic event that has occurred between these two layers of the retina. So these can be the different shapes that are observed in these patients who are suffering from retinal detachments, and the retinal break or the macular hole was responsible for the development of these retinal breaks in these individuals. The signs would basically include an ERG, which is usually subnormal or absent in these patients. And then we have an ultrasonography that is also performed, and that would also relate to the kind of the retinal detachment or the location of the retinal detachment. Now, whenever we are examining these signs and symptoms in these patients, we have to keep in mind that these signs and symptoms are basically related to a Linkoff's rule that we have to keep in mind. The location of the retinal detachment is very important. Then the gravitational forces, they come into play, and the collection of fluid is basically going to relate to the field of vision that is affected in these individuals. So these are the particular rules and regulations that we have to keep in mind for these patients of primary retinal detachment. Then we have a lot of complications that are observed in these particular patients that we talk about. First of all, we can have the primary vitreous traction that is sometimes involved relating to the ora serrata of the retina. So the whole vitreous that is sometimes involved along with the retinal detachment over here. And then we have the cataracts. These can be there can be the mature cataracts over here that are usually associated with this sort of the primary retinal detachment, that is particularly the primary retinal detachment. Then we can have the phthisis bulbi, that is sometimes the final outcome and the final complication. And finally, we have the uveitis. So the inflammatory conditions can be the underlying causes, and as well as they can be one of the complications or the end results of this kind of a primary retinal detachment that is observed in these patients. The treatment would particularly relate to the sealing of the retinal breaks. So, as we've already focused on the fact that it's basically the collection of fluid, so our final treatment would be relating to this kind of a sealing. Now, this sealing is done in multiple methods over here. As we would say, there can be a drainage of the serous retinal fluid that is followed by that. And then we have the maintenance of the chorioretinal appositions. This maintenance can be performed in a lot of ways. There are multiple ways for this kind of the chorioretinal appositions maintenance. One of it is the scleral buckling that is performed. That is again a pressure that is an external pressure on the sclera that is given for these patients. And then we have the pneumatic retinopexy. We have the pars plana vitrectomies. We have the endolaser photocoagulation done for these patients. And finally, we have the internal and the external tamponids that are performed. Sometimes all of these methods are not segregated, or sometimes it is the coupling that is done for these patients. But the general outcome or the general methods that are applied is to first of all seal the retinal breaks as soon as possible, perform the drainage of the retinal fluid, and then perform the coupled methods in such a way in these patients. So finally, we have the cryocoagulation even done for these patients. And as you can see over here, this is done over here. This is a cryoprobe that is just mentioned over here, and it's usually done under the direct supervision where we can perform even the tamponade phenomena or even the external pressures are put to assemble these retinal breaks or these retinal holes or these macular holes for these patients. The tip temperature is usually minus 70 degrees centigrade, and the freezing of the tissue is done whenever this probe comes in contact with the external layers that can be the sclera, that can be the choroid or the retina itself in these cases. So the drainage of the serous retinal fluid was the second step. It is done, and then after that we can perform the scleral buckling for these patients as well. The exudative fluid can be of different kinds. It can be an inflammatory processes that were resulting into that exudative fluid. It can be the tumors that are present in that potential space. So if it's the tumor, we have to perform the enucleation. We have to completely disregard this kind of a tumor in that potential space, and then we perform the scleral buckling or the tamponade phenomena that we talked about. So this is the buckling phenomena in which we are performing the external pressures on the retina, and the final outcomes or the final prognosis in these patients would be very good in such a case. Then finally, the pneumatic retinopexies are performed. We can perform the pars plana vitrectomy in these cases as well. The endolaser photocoagulation techniques are used, and sometimes there is a coupling of all of these methods in these cases. The prophylaxis for these patients would be in a lot of cases, we can perform cryotherapy in patients who are potentially more viable to the development of retinal detachment, and sometimes laser photocoagulation is coupled up with this kind of a prophylactic treatment in these patients. Once we are done with the primary retinal detachment, we have the exudative serous retinal detachment in these patients as well. As we already talked about, these can be the inflammatory cases or the exudative cases that are responsible for the development of such conditions. The etiological factors would basically include the inflammations. It can be the sudden hypotonies. Then we can have the neoplasms that are responsible for these exudations. And then finally, we have the choroidal neovascularizations in these cases. So these are the risk factors for the development of the exudative kind of retinal detachment. And this exudative fluid or this inflammatory fluid is basically again collecting between these two layers of the retina. Then finally, the vascular diseases, the uveal effusion syndrome, and in a lot of cases, a lot of systemic diseases are related to such kind of the retinal detachment, mainly the SLE, Sir George's syndrome. These can be some of the causative factors towards the development of retinal detachment in these patients. The clinical features in these cases would be the absence of photopsia. So if we compare it with the primary retinal detachment, the main complaint or the main symptom over there was the development of photopsia, the floaters or the flashes of light that we talked about. And then we can also observe the neovascularization in these patients. There is a smooth exudative retinal detachment. There is a shifting fluid phenomena that is observed. And then we have the trans-illumination tests that are performed for these patients. The investigations that have to be carried out in these cases are the ocular and the systemic examination. Obviously, if we are focusing on any systemic factors, we have to rule out whether the patient is suffering from any kind of inflammatory conditions or not. CT scans are performed for these patients, MRIs are done, beta scanning ultrasonography is done for these patients, and then finally, we can perform the fundus fluorescent angiographies for these patients. So these would be the list of investigations that we have to keep in mind, whether it is a primary rhegmatogenous kind of a retinal detachment or an exudative kind of a retinal detachment in these cases. The treatment of the exudative retinal detachment would consist of the inflammatory cause have to be treated because that is basically the underlying cause over here. Then the vascular causes are to be treated in these patients, and then obviously the tumors, if these are the underlying causes, they have to be treated in these patients as well. For the inflammatory causes, we have to focus on the medical management. Any other long-standing inflammatory cause, we can relate to the use of the steroids or the antibiotics. The vascular causes are medically managed, or even the lasers can be done. For example, the laser photocoagulations can be done over here. Tumors are treated if diagnosed, and biopsy is done, and then there are finally you can perform the chemos or the radiations for these treatments as well. The medical management would include the unresponsive medical management. Usually the bullous retinal detachment is associated with these unresponsive cases. In this case, we perform the drainage of the retinal fluid. And if it is a case of a tractional component or a rhegmatogenous component, we can perform the scleral buccal vitrectomy. A scleral buccal is put out on the sclera, as well as it is coupled up with the vitrectomy procedure. That is basically the pars plana vitrectomy that is performed in these cases. It can be coupled up with the tympanids, whether they are the primary tympanids or the secondary tympanids in these cases. Then we have another major category of the retinal detachment, that is basically the tractional retinal detachment in these cases. The etiologies would be, obviously, it can be a post-traumatic tractional scar or a tissue that is related to the development of this kind of a condition, proliferative diabetic retinopathy, post-hemorrhagic retinitis proliferans. And then we can have the retinopathy of prematurity. So these can basically result in a tractional force on a retina which is already predisposed, and these tractional forces can basically result in the tractional kind of retinal detachment. Plastic cyclitis is one of the causes as well for this kind of a tractional retinal detachment in these cases. Then finally, we can have the sickle cell retinopathy. We have the Eales disease, that is a proliferative retinopathy in the Eales disease, vitreomacular traction syndrome. Incognita pigmenti is one of the condition, and then we have the retinal dysplasias and the toxocariasis in these conditions. The clinical features for this kind of a tractional retinal detachment would include the presence of the vitreoretinal bands. The retinal breaks are to be looked for, the elevation of the retina, and then finally we have to look for any reduced retinal mobility that is observed on ophthalmoscopy. Now, the treatment that is related to this kind of a tractional retinal detachment is again very important. We have to focus on the etiological factors that basically were responsible for the development of these tractional forces. If it's the neovascularization that we are focusing on in these patients, we would be particularly related, the treatment would be particularly related to the concerned neovascularizations over here. So it can be the cryotherapies that can be performed for these neovascularization. It can be the laser photocoagulation that are done for the retinal breaks or the retinal tears that were the predisposing factors towards these tractional forces or towards the development of these neovascularization in these patients. You can recall that all of the retinal degenerations, they basically resulted in the neovascularizations, and these neovascularizations, they give way to the fibrovascular tissue in the vitreous that is basically pulling off, or that is basically giving the tractional forces over here. So the treatment would be concerning these underlying causes over here. We can relate to the pars plana vitrectomy that can be performed in these patients. Sometimes it is usually done under direct ophthalmoscopy for these patients, just to have an overview, and then we can perform the scleral buckling for these patients as well. Cryotherapies at almost 45 degrees, minus 45 degrees centigrade, they are performed for these for the repairment of the retinal holes or the retinal breaks for these patients as well. So all of the techniques, they are usually coupled up for these patients, and sometimes if these tractional kind of retinal detachments, they're associated with some sort of complications. For example, it can be the cataract. We can treat the complications itself. It can be the phthisis bulbi. It can be an increased intraocular pressure. So whatever the case is, or the vitreous hemorrhages. So all of these are basically pulled off, and they are kept in mind. Whatever the complication is, we're going to treat that complication. Whatever the underlying cause is, we are going to really subject to that kind of underlying or the etiological factor that we're going to see in these patients. So the treatment is usually not isolated in these patients, is usually a coupling or a coupled method that is used for these patients of tractional retinal detachment. So in this particular lecture, we just focus on the different sorts of the retinal detachment, the three major categories ranging from the rhegmatogenous kind of a retinal detachment. It can be an exudative, or the processes of inflammation are sometimes put into the causative factors of the retinal detachment. And then finally, we have the tractional kinds of retinal detachment. So these are basically the three major categories for the development of the retinal detachment in these patients. Whatever the case is, we should know how to deal with these particular cases, how to diagnose these particular cases depending upon the clinical picture of this particular patient that we're going to talk about. And then finally, the prognosis in these particular kind of cases, the vast variety of treatment guidelines or treatment modalities that are available to manage these cases is again very important. So one should know how to deal or manage these cases. And that is the end of this section. Thank you for watching sqadia.com.